There, I'm Leah Bachani, host of the Women Aging Powerfully Summit, and I'm really excited to share this game-changing conversation with you. So, have you ever wondered why your doctor might have dismissed your hormonal symptoms or offered limited solutions? Well, my guest today has spent decades challenging the conventional approach to women's hormone health, especially when it comes to one critically overlooked hormone, progesterone. So I sat down with Carol Petersen, who is an extraordinary compounding pharmacist, and she's also a certified nutritional practitioner. Her expertise is bioidentical hormone replacement therapy, and she has transformed thousands of women's lives. Her passion for optimizing women's health has led her to become a powerful advocate and educator in this field. She has really impressive credentials, including founding the Compounding Special Interest Group with the American Pharmacists Association, chairing the Integrated Medicine Consortium, and serving on the medical advisory boards for the Center for Menstrual Cycle and Ovulation Research and the Institute of Bioidentical Medicine. I know that's a lot, but she has the credentials to back up what she's saying. And as you hear in our interview, she's going to reveal eye-opening insights about progesterone that every woman needs to hear. I mean, we talked about the profound impact on anxiety, on sleep, on brain fog. It's progesterone's surprising role actually in insulin regulation and even in histamine responses. And what I really love about Carol's approach is that she combines this deep scientific knowledge with practical, accessible solutions, like stuff you can literally try today, right now. So whether you're dealing with perimenopausal symptoms, postmenopausal challenges, or even a lifelong hormone imbalances, her wisdom could really be the missing piece in your health puzzle. So go get a comfy seat, maybe get a notebook and a pen. This conversation might just change everything you thought you knew about your hormones and how to reclaim your well-being. Hi, Carol. Welcome. I'm so happy to have you here today.
Oh, thank you for the invitation. It's my pleasure.
Well, I decided that when we were having, this is an annual summit for women's health, and I really wanted to drill down into progesterone because to me, that seems like, and you're the expert, you can talk all about this, but as women enter this midlife hormonal shift, it seems to be the first hormone that kind of goes a bit wonky. And perhaps it's always been a bit wonky for us women. I don't know. We can get into all of the details on that, but some of the symptoms that first make a woman wonder, like, what's going on? Is my hormonal shift happening now? What is this? What can I do about it? And I feel like crap and oh my God, help. So that's kind of what's going through every woman's mind. What made you want to dive into progesterone itself specifically?
Well, it's a quite a long story. I started working for Women's International Pharmacy over 30 some years ago. And the whole purpose of our business was to duplicate the work of Dr. Katerina Dalton in severe PMS.
Mm.
And Dr. Dalton not only characterized PMS, that's where premenstrual syndrome comes from, Dr. Katerina Dalton, but also she devised the treatment. And the treatment was progesterone. And progesterone is a very generous dosing, like 400 to 600 milligram vaginal suppositories. Although our first treatments were just injectable, which everything's absorbed. So not only are these doses nice and generous, ironically, she writes that progesterone levels, when you measured the serum, were normal. These women didn't necessarily have low progesterone that you could target. Another interesting fact I found from her writing was the serum levels of progesterone versus a sample from the peritoneum inside the gut, the fluid inside there was like 1,000 times higher. So it bears repeating because hormones compartmentalize. We know this from our breasts are very estrogen sensitive. Some tissues like a urinary tract, huge number of testosterone receptors are there. So it doesn't go into your body and spread around equally. It's unequal. And hence we have some really big problems trying to measure progesterone and make any clinical sense of it. So that's a problem. On, on the plus side, the clinical symptomatology is really, really clear. And some symptoms like just disappear quickly. So the women that you spoke of that they could be in their 20s, 30s, 40s. And some of them say that the change was abrupt. Like one day, their whole life changes, or it can be gradual. And the first symptoms may be vasomotor, sleep problems they're getting complained about a lot, sometimes brain fog, anxiety, anxiety and when their life should be just fine. And putting on visceral weight is a biggie. So all of a sudden, they don't know what's happened because they changed nothing in their life, but their body is changing dramatically. And this is a key spot where progesterone drops. And progesterone may have become depleted. It depletes when there's exceptional stress. Cortisone from the adrenal glands depletes. Progesterone can help make that up, but it gets depleted too. Pregnenolone, the hormone that's the next one made from cholesterol and precursor to both progesterone and corticosteroids, everything gets depleted. It can be acute stressors, chronic stressors. It can be a number of things, but nonetheless, this is deplete. And progesterone is like a miracle. And why it's a miracle is because some of the symptoms of progesterone deficiency, like anxiety and sleep problems, can disappear that same day if you use adequate progesterone. It's amazing. And then others will take a while, like restoring your bone, because progesterone provides new bone growth. That's going to take a while. But because of those symptoms, responding to your progesterone dose so quickly, that makes it really easy to dose the progesterone and have relief right away. I have no, what's the word I'm looking for? I have no respect for doctors who may look at a patient like this, give them some Band-Aid therapy, say, see you in 3 months, 6 months, and let the poor person cope. And they start out on whatever was given to them and don't do well. It's really important that in the first few weeks that women start on some hormones, if they haven't already done the research themselves, they need some guidance and they need to be able to change up really, really quickly. Why not? Why are you going to suffer for 3-6 months? So
Thank you. No. Well, can I interrupt you for a second, Carol? You
Sure.
mentioned something about, well, you kind of touched on the difficulty in testing and getting numbers, but then you also touched on something that is a pain point for many women, and I don't think they actually realize it, is that anxiety listed as one of the symptoms, which I think many women actually suffer from. And we're starting to talk about it more, but they're going to their doctors and they're getting a prescription for an anti-anxiety medication, when what I'm hearing you say is that perhaps for many, or some at least, of these women, it could be a progesterone deficiency.
it probably is. There's no benzo
So
deficiency.
we're missing that.
We're totally missing it, and it's a problem. If you get on these drugs, I was really excited. A nurse practitioner I know was invited to present in my town, like how to get out off of benzos. I thought, oh, good, I can learn her secrets. No, she comes and she tells me, I said, so what's the secret? How do you get off safely? And she said, oh, you just lower the dose like every 5 days, some percentage. I figured, I go,
And
and no, there was no and. I thought I was going to unlock the mysteries. There are a couple interesting things about the benzos is they're hard to get off of, like Ativan and Klonopin. You get hooked on those, it's really hard to get off. My theory is that if you supply the hormones, that you have a better chance of easing off because you're supplying what you're missing. Now, I have no proof in the pudding, and it still is difficult. Some women have just stopped cold turkey, and I don't know how they manage it. It cannot have been pretty. One of the things I saw when this nurse practitioner came, which reassured me a bit, because progesterone acts at the GABA receptor in the brain, where part of its calming activity comes from. Benzos actually work on a different part of the GABA receptor, because I was thinking, are we wasting our time and money putting in progesterone when you have that in place? And supposedly she told me that GABA receptor has about 40 sites, and they're different. So I said, good, that gives me a better chance of putting in progesterone and having it actually do something and be there for a woman who's trying to get off of the benzos.
That's fascinating. And do you work with clients or patients that are seeing benefit from adding the progesterone when they're experiencing things like anxiety?
Yes. Okay. This is interesting. For a long time, I thought the biggest thing was the GABA receptor. And you can use some GABA itself for this as well. And many herbal products will be calming and work there as well. But there's another mechanism that causes anxiety that really needs to be addressed, and that's high adrenaline.
Mm.
And
That's
so
most of us, I think.
I know this is a big, big problem. So I like Michael Platt's book on adrenaline dominance. And if you're in this constant state of anxiety, nervousness, difficulty in getting to sleep, or you start sleeping and wake up in the morning, mid-morning before it's dawn, and wake up and you can't get to sleep again, that's adrenaline. Some people say it's cortisol doing it. I would submit if you went to the drugstore and bought yourself 1 tube of hydrocortisone 1% cream, hydrocortisone,
Yeah.
cortisone are the same thing, and rub the whole thing on you, you wouldn't feel a bit of anxiety. It's the adrenaline that goes up along with cortisol. I think the cortisol is probably going up to try to protect you from that adrenaline. That's my theory right now. So the adrenaline can go up in response to insulin and glucose surges. When your blood glucose goes down, up goes the adrenaline. And one of my colleagues has a number of her clients wearing glucose monitors, the continuous glucose monitors. And for example, she reported to me that when a woman had a vasomotor thing, hot flash, night sweat, that blood glucose would go down to 30, 50. If you've ever had a fasting blood glucose done, you know the normal is like 65 to something, let's say 120. You have taken a big hit. And so adrenaline surges up to bring that glucose back up. Cortisol goes right on with it. And now you have a big cortisol effect, which in turn can cause other metabolic things, like it'll interfere with your thyroid, it'll interfere with testosterone. It will be a weight gaining, water retentive kind of state when the cortisol is continuously high along with high adrenaline. So many women in perimenopause actually end up in the hospital because of the high adrenaline. They find themselves all of a sudden having heart palpitations, and and they think they're dying. And some women have even reported to me they feel so awful they think they ought to kill themselves. The feelings are so intense. So off they trot to the emergency room. And what do they do there? they put them through a battery of tests to check how their heart's working. Well, their heart's perfectly fine. It's no problem. And they get sent home with no answers. But it is the adrenaline stimulus that's caused all this problem in the first place. I have a theory, and this is a couple things. So that high adrenaline, um, because it's causing all these palpitations, it causes a rise in blood pressure too. 3 classes of blood pressure medication are specifically designed to dampen adrenaline.
Mm.
Interesting, eh? So I'm thinking if you're running to the hospital and you have to have a drug given to you, how about a beta blocker, which blocks adrenaline effect, like propranolol? And this particular drug has been used like for people who are musicians, performers. They get this high adrenaline and it's a little too high and they can't perform if they don't get calmed down a little bit. So they get a beta blocker, which is blocking the beta receptor, which is where adrenaline works. So that calms them down. Now, I don't particularly like that, but if you had a choice between that and days of cardiovascular workup when you don't need it, why not a trial of that?
Yeah. And how does progesterone play into that adrenaline, cortisol?
Okay, so in Michael Platt's book, he submits that progesterone is a good balancer for adrenaline. And yes, I think in real practice, it does do that. And so does hydrocortisone. When you run out of hydrocortisone and put it back, it'll balance it. So does pregnenolone. But progesterone will make you calm when you have that kind of anxiety, which would go along with rapid heartbeat and busy mind. You can't calm your mind. All of that's with the adrenaline kind of situation. So the trouble with progesterone is whereas it's a balancer, it's not going to shut it off. The adrenaline's going to persist. So about 40% of the population, I've seen that number dallied around, excuse me, do not methylate well. And you can determine this from high homocysteine levels on a serum test. If you've done a urine test and you happen to get a high 4-hydroxyestrone, that accumulates when you can't methylate it. The next step is methylation. Should be 4-methylestrone, the next one. So if you're hung up on that, you need to methylate it away. So this constant level of anxiety too, I would say, if you don't have the reaction with the adrenaline and quickly get it to dissipate, you're probably having trouble with detoxification of that molecule. The methylation pathway is really important. It helps you methylate estrogens, helps you methylate histamine. Now, histamine is very interesting because inside the mast cells is a whole hormone factory, just like like your body does with the organ origin of hormones. And when estrogen is dominant in the mast cells, histamine will be released. When this is balanced with progesterone, no histamine release. So again, progesterone can stop the activity. It's no good at doing anything with that histamine once it's released. Then you need something else for that DAO enzyme, and methylation will help you get rid of this. So progesterone is a powerful antihistamine that can be used, and some of these perimenopausal symptoms actually are histamine reactions, like pain in your stomach, skin rashes, hives. Women come up with some strange hives and nobody knows what to do with it. That's histamine.
So do you just slap some progesterone cream on that, or what do you do?
Well, you use progesterone regularly because
Okay.
it will prevent it. But I had one client say her first dose of progesterone, her stomach pain went away. just amazing.
One dose.
One dose. I'm so surprised. And the interesting thing here is that when we apply progesterone, it's used in the mast cells. Our brain makes all the hormones from cholesterol inside our brain, nothing to do with any other organs, and uses it right there. But if you use progesterone, you will affect the GABA receptor
Mm.
inside the brain. It'll accept it, even though it didn't make it itself. Another place is all the neuronal tissue, the Schwann cells that protect the nervous system tissue, the myelin sheath that protects all the nerves. Those cells make progesterone and pregnenolone independently and use it right there. If you have some neurological things going on and you use progesterone, those cells will accept it and use it.
Are you talking? I'm sorry to interrupt, Carol. Are you talking about things like Raynaud's syndrome, MS, other
I
issues?
certainly would try.
Okay.
Definitely. In some of these things, you can document low progesterone sometimes. I had a
Yeah.
gentleman who couldn't feel his feet. I put some progesterone on him, and a little while later, he comes up to me and said, "What did you do to me? You scared me." Just like he said, "I feel my feet."
Feel like it's not witchcraft, it's just
It just
progesterone.
is, it's just progesterone, which really makes me really wonder at the loveliness of using progesterone, the many things it can help correct. I put a blog on my website about the progesterone deficiency symptoms. And I think every woman should go there and just print it out, circle out what's going on with you, use progesterone, and zero all that out. Some of
Mm.
those symptoms there, like I talked about hot flashes being like under insulin glucose control, where progesterone is helpful. It brings up a low blood glucose. So those insulin glucose swings that you can get are moderated by progesterone. In fact, it's a good idea to have progesterone at mealtime. If you're brittle with insulin and glucose, it should stabilize it a bit.
Hmm. Interesting. Well, this is fascinating. And
You just
I wasn't even just like, do you think this is a complete side note, but I hear so many men and women talking about losing sensation in their fingers and toes, not when,
Mhm.
a little bit with the change of the weather, but also just daily. And what I'm hearing you say is it could be, especially in a woman's case, but possibly in a men's case too, a
Oh,
lack of progesterone.
absolutely. I just wrote a blog on that. It took me a long time because I feel men are really underserved. Um, it took me a long time to find enough studies and not rats and mice. I went people studies to demonstrate the effectiveness of progesterone in men.
Hmm.
And I finally put it together. So this progesterone in men will help reduce prostate enlargement, which is really prevalent.
Yeah.
That's also tied up with insulin glucose and maybe high estrogen, for sleep, for trauma. If you've ever had any head trauma, you're probably low in progesterone. Better oxygenation, maybe you won't snore. Um, just a myriad of things, and calming the anxiety, and of course,
Yeah, I want to talk more about that. I'm sorry to interrupt you, Carol. Um, I think we need a whole nother talk about men and progesterone because that is fascinating. And the reason I wanted to just bring it up again was because a lot of women are listening, and women are the caretakers, often if they have a spouse. And we are also usually the ones that are listening and paying attention and educating ourselves on this material. So for all the ladies listening, that might be something to dive into with your partner if that is also something they're struggling with. And Carol and I will have another chat about that another time in depth, I hope. But for now, like you just mentioned calming. And I want to talk about more about like the symptoms that women are dealing with. You listed a whole long list, and you said on their website that there's even more. Women can go circle what they're dealing with. Are there myths or misconceptions surrounding progesterone, and why is every doctor not prescribing this to every single woman?
Mhm. They should, and every single man, because we are in general, we're having a lot of trouble maintaining our progesterone. Actually, I saw a nice study about long COVID. I have in my slides if we want to go there, but it's
Sure.
long COVID has low progesterone. And the study actually went on to say maybe we should use progesterone. Long COVID also has low cortisol. This is not surprising. These people are dragging out with no energy, no hormones. The COVID, the vaccine and the COVID caused so many miscarriages. What causes a miscarriage? A drop in progesterone.
Oh,
It's horrifying when you think about it.
yeah, that's the first thing my doctor put me on in my second pregnancy when I was having some symptoms. They gave me progesterone.
Yeah, good thing. You're going to
Yeah.
have a brighter, happier child as a result.
I
So,
hope so. That'd be great. Yeah, he's
Katarina,
11 now. He's doing well.
Katarina Dalton actually did this. So
Yeah.
she had severe PMSers on high doses of progesterone and they got pregnant. And so she was afraid to take them off because their symptoms were so severe. And so she just kept them on the generous doses of progesterone throughout the whole pregnancy. Let me also insert here, it's very likely that the nausea you get, particularly in the first trimester, is progesterone deficiency. You're getting plenty of estrogen, but not quite enough progesterone to balance. High estrogen is very nauseating. So you can probably forestall some of that. And Katarina Dalton went so far as 10 years after the birth of these children, she went and checked out the children, as a good scientist might do because of her intervention. And the children were brighter and they were more socially adept than their peers. They did not exceed in sports for some reason in their little survey, but everything else was better.
Well, maybe they were so chill. They were like, I'm just gonna read a book or go on a walk. I don't need to like fight for a ball.
I
That's
know, so
interesting.
it's something to think about. Also, this is kind of curious, and I don't know the answer. I've asked a couple people in fertility work. When you're pregnant, let's say your luteal phase, and the numbers on a lab test for normal progesterone may, if it's very generous, I'll go 20 to 30 nanograms per deciliter. And when you're pregnant, it used to be the textbooks would say like 50 to 200, but I've seen labs that have the pregnancy amount of progesterone all the way up to 550. Huge amounts of progesterone are being produced in your body when you're pregnant. And so I'm thinking there's probably a sweet spot in there that you should have at least so much progesterone. I believe if you're down by the 50s, you may be in high risk of miscarrying. And maybe that's where you found yourself when you were supplemented, that you had some progesterone or you wouldn't be carrying a baby, you'd miscarry, but maybe not enough to be comfortable with to make sure that pregnancy occurs. And I believe so at the end of those pregnancies where you have lots of progesterone. Now you have a baby that's calm, delightful, instead of one who's anxious and crying and colicky all the time. Because of the high progesterone in that pregnancy. So progesterone deficit can start at pregnancy.
Oh, you actually mentioned, I think earlier, that some women are struggling all through their, ever since they start a period, like through their teens and 20s, even with
Yes.
extreme PMS, or even maybe it's not extreme, but it's still low progesterone. So you have me thinking that there could be a lifetime deficiency for progesterone, but maybe women just, they put up with it. Oh, PMS is normal, which it shouldn't be. We're normalizing something that's not normal. And then they get into their childbearing years and maybe they have interventions like I did, or maybe not. But then they get to perimenopause. And I feel like that's when women can't escape low progesterone anymore. It's especially if they have a severe deficiency, their life is so impaired that they're searching for answers everywhere, not getting as many answers as they probably like, which is why they're listening right now.
Right.
And I want to dive into that world and that woman. Maybe she's perimenopause, maybe she's postmenopause. Can you talk a little bit about what are the types of progesterone we can take? How do we know if we need it? Are we going to the right doctors? If we want to do something and take action with our health, like what do we do?
That's like four different distinct questions.
Sorry, give all the answers, Carol. We're waiting. Well, let's start with a woman that's
Women used to ask, should I go to an endocrinologist? And no, because they think they do low thyroid and they think they do diabetes and that's it. And they don't even do that well. So that's an issue right there, the so-called expert. So should you go to your OBGYN? Well, maybe. You would think they would know a little bit about hormones. Some do and some don't. Some have taken courses from the Menopause Society. And if you want to drug your menopause, that's the expert you choose, because that expert will not stick to the real hormones, those identical to human. And that's a number one rule for me. Don't be putting the synthetic junk in your body. It really wrecks your endocrine system. For example, another really common perimenopausal symptom is heavy bleeding. Okay, here's the scenario. For some women, they go to their doctor and complain about heavy bleeding, and the doctor does nothing. They wait until the woman's lost so much blood, she's going to beg for hysterectomy. That's one scenario. Second scenario that's new on the block is to insert a Mirena IUD, which is a progestin. So it blocks your own progesterone. You already don't have enough, and now you're blocking more. So it does, in some cases, not all cases. Some women still bleed with it in. Some women, that seems to solve the problem. But this is so easy to fix, which is what is horrifying about this. Because in the first part of your cycle, this is day one of bleeding to ovulation. This is the follicular level of progesterone. Where does that come from? That's coming from your adrenal glands. So when you're stressed and depleting your adrenal activity, estrogen is quite abundant and it builds up all these big, big layers. And then when you finally do ovulate and shed it, it's a lot. So when you put progesterone in at the follicular time and support the adrenal progesterone, you don't build up those big layers anymore. And it takes about a cycle or two and you're done.
That's fascinating. So if I heard you correctly, the typical recommendation is only in the luteal phase, which if you're a cycling woman, you add the progesterone in the luteal, which is the second half of the menstrual cycle. But you're saying, no, you do it the whole cycle.
Right. If the adrenal progesterone is what you need to help, which has been depleted because of stress, you'll find other symptoms there too. You'll have sleep problems all month, anxiety all month. It actually is a smaller dose in that follicular phase that you need. In fact, you need to stay small because you don't want to inhibit ovulation. Higher doses could. Katerina Dalton probably was talking about a suppositor. She said 100 milligrams should be your top. I'm considering 100 to 200 capsules or creams might be fine.
So it's a little bit of an art where you're finding a dose in the first half of the cycle, if you're still cycling, and then that dose might change in the second half. And so working with a practitioner to figure out those levels would be a good idea.
Okay, in the second half, now the sky's the limit as far as I'm concerned, because those are where the PMS symptoms occur. Now, some women have it from ovulation to bleeding. So they should be taking extra progesterone, maybe larger doses for those whole 2 weeks. Some women don't have any symptoms until mid-luteal, and this is when progesterone should be at its highest, and that's where they start having some problem. And you could wait till the week before bleeding to go way up on progesterone to serve the needs of those symptoms. Then here's another thing that people are not aware of. Some women can experience their worst symptoms 1, 2, 3 days into bleeding.
Mm.
And so we have this urban legend that you have to stop progesterone to bleed. No, that's not true. I know that from the PMSers. They had regular cycles, regular bleeding, and took higher doses of progesterone into the first days of the follicular cycle. And then they dropped down on their progesterone after that. Stopping progesterone does not make you bleed. And this is, everybody is conventionally trained to think so, that you have to stop it. And a lot of people get really confused. Women get confused. Their doctor told them to stop the progesterone and they'll bleed. They don't bleed. So then what are you going to do? Now, conversely, let's say you've been without progesterone for a whole long time in your lifespan, and you start progesterone, and in a little while you do bleed. And then if you're not pre-informed, off you go to your doctor and they do a whole workup for cancer, endometrial cancer, and scare you to death about all of this. But it is a normal, natural function of progesterone. In the luteal phase, first half of the luteal phase, progesterone helps build up the endometrial layer, ready for an egg. When you get to the apex and no egg has appeared, progesterone becomes a secretory hormone. It's making that tissue available to be shed. So you start progesterone and all of a sudden you bleed. And sometimes women have very heavy bleeds. They have a lot built up. It's a good thing to get this tissue out.
You're shedding old lining. Is that what?
Yes.
Yeah.
Oh, yeah. Some people are saying, oh, I'm getting all these clots and brown old blood and fibrous things coming out. That's good to get rid of it.
Hmm. Fascinating. What about a woman that is not cycling anymore? She's postmenopausal. Would Are they taking progesterone just daily then?
Yes, if you want to live well and prosper, you
Ah,
do.
sign me up. I think we all want that. That's pretty safe to say.
Yes, yes. So if you go to any of the anti-aging groups, A4M, age management group, they are teaching, helping add onto your hormones as is really a cornerstone of successful aging. And progesterone is so important. As
Mm.
I said, it's an adrenal hormone, as a ovarian hormone too, which is a little more, but it's still lots of progesterone you're making all the time. In fact, you make more progesterone than you do testosterone, than you do estrogen. So why do we put all our attention on estrogen and just ignore the more abundant hormone, progesterone? I have no
I
idea.
don't know. That's why I came here to ask you. That's why you're here. Tell us.
I think it's a conspiracy.
Oh boy. Well, why though? But wouldn't the world be a better place if women are happy and calm and
Yeah,
aging well?
one client told me this, and she was on some pretty generous progesterone dosing. And, she said to me, she said, nothing my husband says bothers me anymore.
Hmm.
And I go, oh, this is like, I said, you're at a good dose, I think, but imagine what that does to relationships. Just
Yeah.
imagine when at one point even your significant other can't even breathe or chew without irritating you.
Yep. I've been there.
And now it's nothing. And
Yeah.
that's the way it should be and could be. And I hate to see how many relationships just get badly affected. I'm also really impressed when I'm working with women, how many of them have such supportive um, relationships. These guys put up with a lot and they are there to support
Mhm.
us. It's a beautiful thing to see.
That's amazing. So we'll add to the list of potential benefits of progesterone is marriage saver.
I just-
Okay, that's a new one for me. I didn't actually connect those dots, but it makes sense actually. So we talked a lot about, what that looks like to take progesterone, whether you're premenopause, perimenopause, postmenopause, but there's a big question that women ask out there. What is the best form? And there's a lot of controversy and maybe misconceptions. Can you clear up, the form of progesterone that women should ultimately be taking?
Okay, first and foremost, I want to stress that enough progesterone for your needs is the primary thing. Okay, so let's talk about oral. You get oral and oil. The oil's there to help enhance the absorption of progesterone. A lot of people discount oral and say it's broken down by the liver and it's no good. Actually, it behaves as a fat when it's delivered in oil like this, and it's taken up by the chylomicrons into the lymph system.
Hmm.
So less gets destroyed by that usual talk about stomach acids breaking it down. It has an alternative pathway that's used by all fats. So there's that. So it can make a big difference. Now, there's a metabolite of progesterone called allopregnanolone, which is quite strong and acts on the GABA receptor preferentially and could be a good thing, but it also causes drowsiness, dizziness kind of things. And after decades of using progesterone, I finally felt it myself. I had some oral capsules. I decided to take 250 milligrams one morning, and there it was. And I thought, wow, this is what everybody's feeling when they complain. And I had a workup out quickly, and then I ate 4 eggs and it disappeared. I did not get that activity when I used 200 milligrams, for instance. So it could be dose related. Maybe smaller doses more often would be helpful, or switching to another dosage form if that's going on for you and it's debilitating. So let's talk about creams for a minute. So creams have the hormone suspended in the cream base. It's not fully dissolved, so you have to dissolve the progesterone in your skin oils before it can cross the skin barrier. So all well and good, except if you have very dry skin, like if you're a hypothyroid person. And then if you're hypothyroid, the circulation to your skin is impaired. So that's going to be a problem. And then if you're in this high adrenaline state, your capillaries are all scrunched up. So you're not going to absorb that well. And that's exactly when you need it the most and you have the hardest time absorbing it. So transmucosal, it's pretty good. And I mean, vaginal suppositories, rectal suppositories. We used to compound rectal solutions way back when. And then in the mouth, troches, or Dr. Mercola's had a video like get progesterone powder and put it in a vitamin E oil that you squeeze from a capsule and rub it along your mouth. It's a very good absorbed way to do this. Now, women have bought progesterone creams over the counter when they can't get it from their prescriber, and they even freeze their doses so they can insert it transmucosally for better absorption than they would have on the skin. So there's also Quicksilver Scientific has devised a nano emulsion form for hormones, and you can ideally it would overcome the problem with the creams, but it's hard to say. You have to do every person as the unique individual that they are, and adjust from whatever dosing. Doesn't matter which dosage form you took. If you were taking capsules and wanted to switch to cream, you can try maybe the same dose, but you still have to adjust to your needs based on that dosage form. So it could be variable.
One of the things I hear about the creams is that it can accumulate in the tissue. Is that true?
You tell me. I'm waiting to see for the skin biopsy.
Yeah, like what,
For
how
the
would we know
biopsy.
that if it's would we would we have a mutation? What's going on? Like, no, you don't see
This
it.
is an urban myth, I
Okay.
believe. It was started by John Lee. In fact, one of my colleagues wrote a book on hormones, and he said that too. He gave me his book, I read it, and he was saying that too. It's storing in the fat and in the tissue.
Hmm.
I said, "Where's your reference for that?" Because I've been looking for this for decades. It's made up. I'm sorry, but it's made up. And another reason I know it's true, this was involving saliva testing. There was a lab who did saliva testing for hormones, and we had women using nice doses of progesterone for their PMS. They go get saliva tests, and the lab tells them they're way too high, and it's probably going to give them cancer, and they need to quit progesterone for 6 months. This lab was showing women, and they would call in about 3 days crying
I want
because
my progesterone back.
they're already out of their progesterone. It's not this 6 month deal. This is crazy.
Hmm.
Um, and I don't know the answer to that, but I think it's urban legend.
Hmm. Well, and I guess the true marker would be if a woman feels better using a cream or whatever she's using, then that would signify that the progesterone is probably getting used in the places that it needs to be used and absorbed.
Right, it's going all over. So actually, Dr. Joe Robinson from the University of Wisconsin, and he was my professor. I was even thinking about working with him in grad school. He was an expert on skin and eyes, and then he actually worked a lot with progesterone. So we went to him and said, "What about this fat storage theory?" He goes, "It's a bunch of rubbish." He said, it's got to get through your skin. The stratus corneum is the barrier, but once it's through, it's going into general circulation.
Fascinating. Okay, well, I asked that specific because you actually mentioned this too, is that some women are having trouble getting prescriptions of progesterone, for example, from their practitioners, which in that case, I would suggest, ladies, you go find another practitioner. But in the meantime, if they're just desperate, they will turn to over-the-counter progesterone creams. And that's why I wanted to really talk about that. Yeah.
Okay, I'd love to touch on that because it brings up another problem with progesterone dosing that I think everybody needs to be aware of.
Yeah,
If
let's
you
talk about
use too little, you can be made much worse. And
it. Uh-oh.
I just
Okay, let's dive in. This sounds like we need
remember I was talking about going to the emergency room with heart palpitations and thinking you want to kill somebody or you want to kill yourself.
yeah, it's
Small
not good.
small doses of progesterone can do that. The kind that you got in the health food stores, they usually have around 20, 30 milligrams of progesterone in a dose. And for some, that's okay. You know, if you're aging gently and just need a little support, it's fine and good. But if you've already had a lifetime of progesterone deficiency and you've done that, immediately you get an enhancement of estrogen activity. And I think you get an enhancement of adrenaline activity by some pathway because there's all the palpitations too. Or you can have new onset of like a severe headache you never had before, or you've been sleeping fine and you can't get a wink of sleep. Just horrible. One Facebook group, um, which I love, they call it the estrogen kickback. And you need to have a dose high enough that you're not there. Really, you ought to jump up. I believe women should be taking about 300-400 milligrams for sure in the luteal phase and maybe every day post-menopause. Why do I believe that? It's Jerry Lynn Pryor. at the University of British Columbia, and her website is sempcore.ca. She's been studying the menstrual cycle for a long time, and with a particular focus on osteoporosis. Even younger women who were high-performance athletes were blowing through their hormones and getting osteoporotic in their 20s. So she uses in her studies 300 milligrams of progesterone and demonstrates new bone growth. I talked to her one day and asked her about this estrogen kickback, and she never ever sees it. She was flabbergasted when I said this is a real thing. It's happening. And why I know it's important, back in those PMS days, when we are treating women with high doses of progesterone for their severe PMS symptoms, women would get like a certain amount, and it could be a couple thousand milligrams of progesterone, probably various dosage forms, and they would have, we called it estrogen breakthrough. On particular time or day, that dose didn't suit them, and their doctors would give them like a lozenge to make the progesterone go up quickly, or they get directions to use more progesterone quickly, and it would work. So if you run across a situation when you're using progesterone seems to make you worse, immediately increase the dose. I've seen it in the medical literature, and they don't call it an estrogen kickback, they call it an inversion. And some drugs actually work this way. At some doses, the response is negative. At other doses, you get the response you want.
Do you also see, so is it kind of like a bell curve where if you're taking too little progesterone, you might have really bad symptoms? You
Yeah.
get the perfect amount, you're good. And then if you have too much, you have those same symptoms come back or similar symptoms?
What's too much though? You've got to get over 550.
Okay, okay. All
And
right. Well, it's interesting. I'm really glad that you brought that up because, we're taught that typically if you're taking something, let's say it's the progesterone and you're having the heart palpitations, the immediate reflexive response is to stop, to back off. And you're actually saying that it could be the opposite, like you need to keep going immediately.
right, you can flip that over immediately. So what's going to happen to you if you stop? You're going to suffer for a few weeks because all the havoc you started,
Oh,
and
wow. Well,
it's not good. And then you're going to have uh, an intense dislike of progesterone, which is the very thing that could help you. And as a practitioner, if you're a practitioner, you're going to be hated. And because you haven't pre-warned that person that
yeah.
too little a dose, use more right away. I have a blog on that too. Women who
Mhm.
don't like progesterone. Progesterone
Aptly said.
should be your friend. And if it's not, there's reasons for it, and it's in my blog. But using more right away. You can treat a headache, migraine headache. One practitioner I worked with on a blog, she had a 30-year history of migraines, just disappeared as you use progesterone, like every 15, 20 minutes to get it stopped.
Wow. That's incredible. Okay, I would be remiss if I didn't ask you this because I know women are wanting to know this too, and this is kind of a controversial topic as well, is for the post-menopausal woman who's, 10 plus years post-menopause, there is a circulating statement from many people that you should not take any bioidentical or hormone replacement therapy of any sort because you're 10 plus years post-menopause. What do you have to say about that specifically with progesterone?
Where that came from in the first place was WHI, Women's Health Initiative study, and probably somebody else will explain it. And first of all, this garbage study, because it uses Premarin, which is a collection. I have a study that identified 60 different steroid type hormones in Premarin, 60. And not all of them were estrogenic. Some were very progesterone-like, some were testosterone-like. So we have this mess. And then we put a synthetic medroxyprogesterone acetate or Provera as instead of progesterone. So you get a bunch of garbage data because you started with garbage. And I really protest that we don't do studies on the real the real thing adequately. And so they decided, the wisdom of the WHI said, you shouldn't take hormones after 65, or I think it was 65 was the break off, thinking that, oh, you're going to have your worst vasomotor things, 55, and so, and we're only using the hormones for that, and then you better quit because we don't know what's going to happen to you, right? But and later this was retracted. This got a lot of publicity, but there was a study retracting that limiting thing, and part of the press didn't take that up, as they could have said, rejoice, we're taking the hold off. And that didn't happen. So symptoms of aging are highly correlated with hormone deficiencies. And so if you want to age at your very best, it's quite safe, and actually a wonderful opportunity in this day and age to top it off. I've personally been using hormones for 35 years, and I'm never going to stop because it has done so much help for me. I'm just going to continue. And I play around with protocols and do this and that, but it's fundamentally helping you avoid a lot of misery. Let's say you go on without it. Okay, you're going to have this adrenaline stuff, so you're going to have high blood pressure, you're going to have insulin glucose off having all these spikes, causing a lot of dizziness, anxiety kind of thing. You're going to be pre-diabetic, diabetic. You're going to be drugged for that. You're going to be drugged for sleep. You're going to be drugged for depression. Drugged.
Lots of
Whatever.
drugs. When you could potentially add a bioidentical hormone that your body used to have a lot of and now just doesn't have as
Right.
much, and just supplement with that and perhaps avoid many of those.
Right. So what would you choose?
I'm going with the progesterone. All right. I'm going with the progesterone and then probably estrogen and maybe testosterone, but that's a whole nother conversation. So I don't want to overwhelm people with that.
What's really exciting, I think people ask me about testing too.
Yeah.
And as I mentioned earlier, there's no really good test, and unreliable parts of many of them. But what I'm doing with my clients, I have a big metabolic panel, and I have all the hormone systems, pituitary hormones, complete
Mhm.
thyroid panel, insulin glucose markers, lipids, sex hormones, adrenal hormones, inflammatory markers. And there's a lot of information you can get from that as far as how you're needing to manage your hormones, or you need to manage your metabolism, your metabolic rate, is all in there. So I like that for initial workup, particularly perimenopause, which is very goes all over the place. So for example, if you go have a test and you just have serum estradiol, in perimenopause, it could be high, it could be low, it fluctuates a lot. So how do you really know that that's an accurate number for you? In fact, what I really don't like is women go and get that test, and that's their number until the next time they get tested in a year or two. and
And
it's
by serum, you mean blood, just
I
for just
yes,
to be clear for women
yeah,
listening. Yeah. Yeah. Okay.
yeah.
So the blood test is a tiny little pinpoint in time of,
Right. It's not your number for the
yeah.
next year.
Yeah.
And you can have clues to estrogen by other things. I like to see total estrogens instead of just estradiol, estron. That can be larger. I like to see sex hormone binding globulin, because estrogen has a stimulating effect on the liver to make more when there's lots of estrogen. There's prolactin,
Mhm.
pituitary hormone. Prolactin goes up in the case of high estrogen and low thyroid. So you can get a better idea of the real estrogen status kind of indirectly, instead of at just one point.
And so do you do a combination of a blood panel, urine, and saliva, or no?
I just do the blood.
Okay, got it. So,
There's nothing that the other tests can give me in addition that I don't get from this whole panel. In fact, there's more from this whole panel than the other specialty tests.
fascinating. Okay, there's a lot of differing opinions on that, which is to me, it's just fascinating about how this all plays out because no wonder women are confused. There's so many different options and, different practitioners practicing different ways with their patients and
Well, if you go to a conventional practitioner, they've never heard of urine testing for hormones or saliva testing for hormones. They just never heard of it. So why would they jump on the bandwagon? Of course, nobody else is doing it. So so you have to seek out people who are, specially trained. And then my only objection is get as much information as you can.
Mhm. Yeah.
For instance, I'd like to say something about this too. It's the great cholesterol scare. You need to have your cholesterol, embrace your cholesterol. There's literature to show that total cholesterol 220 to 280 for best quality of life and best longevity. So what are you doing with this statin to try to knock it down? And then you can't replenish your body. Every cell in your body needs cholesterol, and you certainly can't make your hormones.
I
And
can't tell you how many women are scared by cholesterol numbers that their doctors are saying, that number, it's too high, you must lower it. And women are scared about that. And if you look at the numbers that were accepted and touted, 50 years ago, 100 years ago, it's very different.
very different, but we haven't changed. We certainly haven't changed. So you get this blood test, and it's got all these red high things. It's designed to scare you. It's designed to scare you right into a statin. And in women, I don't know of a single study that shows any benefit for no increased lifespan or quality of life. What are you buying? And then men, there's only one study, the Jupiter study, and they found that, and this was after already a heart incident and was for prevention of a second one. They found that you needed to treat 200 men to have one avoid a second event. This is really not a good drug. Why would you spend 199 men have to suffer the side effects and the cost of the therapy for one person to benefit? This is bad math all the way around.
Yeah, I'm really glad you brought that up because that's another topic that I think that we should discuss. Unfortunately, we're at taking up an hour of your time. You've been so gracious about sharing all this incredible information. But I would love to have another conversation about that. And, women and cholesterol it's not talked about enough. And I'm very grateful you brought that up. So, Carol, I mean, there's so much. I'm gonna have to go back and watch this. I say that every time about every expert, but you guys are just so knowledgeable and pouring into us with so much information. I'm so grateful. Um, Ladies, you probably have to watch this again and take some notes because it was so good. Before we leave, Carol, one last question. What is one takeaway that you hope that women at this summit leave with about progesterone and aging powerfully?
Okay, here's my suggestion. Do not settle. Absolutely do not settle. If you are on a protocol trying something and you're like 80% better and some things are not quite right, don't settle for it. Be your own advocate. You need to be 100%. And a lot of people will leave you in this less than perfect situation. It's possible to be completely delighted with your hormone therapy or some of the other therapies to make your life more worth living. So it's possible. So do it.
I love that message. Don't settle. Ladies, you heard it here first. You've been given a lot of tips and tools to empower yourself now. So, go out and advocate for yourself and don't settle. I love that message. Thank you so much, Carol.
Thank you, Leah. I'm glad you like it. And thank you for this opportunity.